Hey, welcome to Rightfocus Healthcare Educational Channel. I'm GB. Today's video is a short video discussing changes in COPD treatment guidelines as a review for primary care nurse practitioners or pulmonary care nurse practitioners. What changed in 2024-25 with the GOLD guidelines? GOLD is Global Initiative for Chronic Obstructive Lung Disease. I recommend nurse practitioners or any providers watching this video review the COPD previous video in the channel where I explaining about COPD, causes of COPD, how to diagnose it, mMRC scale, CAT assessment, staging of COPD, and treatment in detail, and the different type of inhalers which can be used in COPD. In this video, I'm only discussing any changes in the GOLD guidelines from 2024 to 25. Next, you can see in the screen, there are two boxes. The first one is the GOLD criteria for severity of airflow obstruction in COPD prior to 2024, which is ABCD classification, and the next one is ABE classification, which is a new GOLD criteria after 2024. As we all know, the official diagnosis of COPD is by FEV1 FVC ratio, which should be less than 0.7. Then we can diagnose COPD. And other classifications are like staging of GOLD 1, FEV1 is greater than 80, GOLD 2, 50 to 80, GOLD 3, FEV1 30 to 50, and GOLD 4, FEV1 less than 30. Means if the GOLD criteria is higher, the airflow limitation is more, and those patients need help. All FEV1, FVC, and a pulmonary mechanism I have explained in a previous video of COPD. Please refer. Then the pulmonary function test, GOLD has added two more tools for measuring the COPD severity. Number one is mMRC dyspnea scaling, which is Modified Medical Resource Council dyspnea scale. So what that assesses is the severity of the symptoms in a scale 0 to 4 grading. So the higher the gold grading, patient has more symptoms. For example, the 0 means patient get only breathless with strenuous exercise, while 4 means breathless on a small activity. Next tool is a CAT assessment or COPD assessment test. It is a scoring from 0 to 40 on 8 items, which range the score 0 to 5 on each item. What that means, the higher the CAT scoring, the symptoms are more and patients can tolerate only less. For example, I never cough, that will be a 0 score, and then I cough all the time, that's a 5 score. And then I have lots of energy, 0. I have no energy is 5. So in summary, if the CAT score is higher, the patients can only tolerate less activity. Okay, let's look at the table and explain. So the first table, mMRC is 0 to 1, which means fewer symptoms for A, and then mMRC is greater than 2, which is more symptoms for B. But when it comes to C, the fewer symptoms, mMRC is less than 2, but on the side you can see exacerbation or risk or hospitalization. They have fewer symptoms but more hospitalization. D, the same, CAT is greater than 10, mMRC is greater than 2, so there is more symptoms but also there is more hospitalizations. So what is the change in GOLD criteria after 2024? Look at the first one. A, fewer symptoms, low risk, CAT is less than 10, mMRC 0 to 1, it's the same. Next one, B, more symptoms, CAT is greater than 10 and mMRC is greater than 2, more symptoms but less risk and less exacerbations or less hospitalization. Now the difference is that the C and the D merge into a new group called a group E. So it's more symptoms there, and also there is more exacerbations or more hospitalizations. It's a change after 2024. If you already was following the GOLD criteria of classification and treatment, there is not much change except the C and the D group merge into a new group called a group E. Other than that, there is not much big difference. Fewer symptoms, low risk. We uses a bronchodilator, which is SABA, short-acting beta-2 agonist, Proyer or Ventral in 1 to 2 puff, Q4 to 6 hour PR and shorter breath. And then B, we use start with an initial therapy, LABA like Cerivent, or LAMA like Spiriva as a monotherapy. And if symptoms persist, go to LABA plus LAMA, which is a combined therapy. But in clinical settings, what we see is that patients will be already on these combinations because of the samples availability. So what we have to do is that assess their SABA use, and they're based on their PFT, we can reduce the dosage of those medications or can wean down. Examples of those LABA plus LAMA combinations are like Anoro 1 puff once daily, Bevespi 2 puff twice daily. Next is group E management. As we know, there are more symptoms, more hospitalizations. So the initial management is LABA plus LAMA combination. LABA is long-acting beta-2 agonist and LAMA is long-acting muscarinic antagonist. Like we can use Anoro, Bevespi or STL2. And if there are frequent exacerbations or there is an asthma COPD overlap, or if the blood eosinophil count is greater than 300, we can add an ICS, inhaled corticosteroids. So that will make it a 3 inhaler combination, which is trilogy. We can use 1 puff once daily, and then Breztri is 2 puff twice daily. Next is other updates in GOLD guidelines. What is relevant to the scope of nurse practitioner practice. Clinicians are still catching up to the mMRC and CAT, so I'm not discussing in this video any other new screening tools. So let's discuss the major topic relevant. Number 1, smoking cessation. It was always a major one, still the most critical step in preventing COPD progression. GOLD 2024 does not recommend e-cigarettes due to long-term safety concerns. Number 2, inhaler technique. The GOLD 2024 recommends teaching and checking technique regularly, especially in elderly patients. You can learn that from the COPD video in this channel. And these incorrect techniques can lead to poor drug delivery and treatment failure. Number 3, pulmonary rehab. It's recommended for patients who had exacerbations and moderate to severe COPD. And then that has a strong evidence for improved symptoms, exercise tolerance, and quality of life. And then for oxygen therapy, it's indicated when oxygen saturation is less than 88% at rest, and we know how when we do the oxygen therapy. It's not recommended just for breathlessness unless there is documented hypoxemia. Then 5, new respiratory syncytial virus vaccine, RSV vaccine. It's recommended for COPD patients due to high risk of RSV-related complications. It's added to routine vaccines like pneumonia and flu vaccines. Hey, last but not least, if this video helped you better understand COPD updates or any of my videos gave you something useful for your clinical practice, feel free to subscribe to my channel. I'll keep sharing practical tips like this to help us all stay sharp and up to date. Thank you for watching again.